Hey future nurses! Welcome back to the channel. It's your favorite NCLEX study partner here. Today, we're diving into 50 tough NCLEX questions on fluid and electrolyte balance, the kind of questions that really test your clinical judgment and your ability to think like a nurse. These aren't your basic review questions, they're high-level, real exam-style scenarios with detailed rationales and strategies to help you understand why the correct answer is correct. So grab your notebook, stay focused, and let's see how many you can get right. Remember, don't just memorize, understand the concept. Let's get started. Question 1. A client with severe burns is becoming confused and weak. Serum sodium is 128 milliequivalent/L. Which nursing intervention is most appropriate? A. Administer hypotonic 4 fluids. B. Restrict free water intake. C. Administer furosemide. D. Encourage oral water intake. Answer: B. Restrict free water intake. Expanded rationale. Severe burns often cause fluid shifts, third spacing, and can lead to hyponatremia due to dilution. In this case, low sodium, 128, with confusion indicates dilutional hyponatremia. Administering more water, options A or D, would worsen the imbalance. Furosemide, C, could deplete sodium further. Restricting free water allows sodium concentration to normalize and prevent cerebral edema. Strategy tip. When sodium is low, first ask, is this dilutional or depletional? If overhydration is present, restrict fluids before adding more sodium. Question 2. A patient receiving furosemide develops leg cramps and ECG shows flattened T waves. Which electrolyte imbalance should the nurse suspect? A. Hypernatremia. B. Hypokalemia. C. Hypercalcemia. D. Hyponatremia. Answer: B. Hypokalemia. Expanded rationale. Loop diuretics like furosemide promote loss of sodium, potassium, and water. Hypokalemia affects muscle function, cramps, weakness, and cardiac repolarization, flattened T waves. Potassium is critical for nerve transmission and muscle contraction. When low, cells become hyperpolarized, reducing excitability. Strategy tip. Always associate loop diuretics with potassium loss. ECG equals your early warning system for life-threatening dysrhythmias. Question 3. A client with chronic renal failure has serum potassium of 6.8 milliequivalent/L. Which action should the nurse take first? A. Monitor intake and output. B. Prepare the client for dialysis. C. Encourage high potassium foods. D. Restrict fluid intake. Answer: B. Prepare for dialysis. Expanded rationale. In renal failure, kidneys cannot excrete potassium. A level greater than 6.5 milliequivalent/L is life-threatening. It can cause cardiac arrest. Dialysis rapidly removes potassium. Restricting fluids, D, or monitoring, A, is not immediate life-saving care. High potassium foods, C, would worsen the condition. Strategy tip. For hyperkalemia plus renal failure, always think emergency removal, dialysis or 4 insulin plus glucose plus calcium gluconate. Question 4. Which assessment finding best indicates fluid volume overload? A. Flat neck veins. B. Weight loss. C. Crackles in the lungs. D. Increased hematocrit. Answer: C. Crackles in the lungs. Expanded rationale. Crackles signify pulmonary congestion due to excess intravascular volume leaking into alveoli. Other signs include bounding pulses, edema, and jugular vein distension. High hematocrit suggests dehydration, not overload. Strategy tip. When assessing overload, always listen to the lungs, it's the earliest and most sensitive indicator. Question 5. A client's serum calcium is 6.9 milligrams per deciliter. Which symptom should the nurse expect? A. Flaccid muscles. B. Positive Chvostek sign. C. Constipation. D. Decreased deep tendon reflexes. Answer: B. Positive Chvostek sign. Expanded rationale. Hypocalcemia, less than 8.5 milligrams per deciliter, increases neuromuscular excitability, leading to tetany, twitching, and positive Chvostek/Trousseau signs. Calcium stabilizes nerve membranes. When low, neurons fire too easily. Constipation and flaccidity are signs of hypercalcemia. Strategy tip. Remember, low calcium equals twitchy and tight. High calcium equals slow and sleepy. Question 6. A client with heart failure taking digoxin has potassium level 2.9 milliequivalent/L. Which complication is most concerning? A. Seizures. B. Digoxin toxicity. C. Fluid overload. D. Hypotension. Answer: B. Digoxin toxicity. Expanded rationale. Low potassium increases digoxin binding to myocardial tissue, causing toxicity, nausea, visual halos, arrhythmias. Hypokalemia doesn't directly cause toxicity but heightens sensitivity to digoxin. Strategy tip: always check K before giving digoxin. If low, hold dose and notify provider, safety first. Question 7. A post-op client with continuous NG suction has chloride level 92 milliequivalent/L. What acid-base imbalance is likely? A. Metabolic alkalosis. B. Metabolic acidosis. C. Respiratory alkalosis. D. Respiratory acidosis. Answer: A. Metabolic alkalosis. Expanded rationale. Gastric fluid contains hydrochloric acid, HCl. Suctioning removes acid loss of H ions alkalosis. Chloride loss accompanies hydrogen loss. In contrast, diarrhea causes acidosis due to bicarbonate loss. Strategy tip: mnemonic. Vomiting or suction equals alkalosis. Diarrhea equals acidosis. Question 8. A patient with hypovolemia is receiving 4 fluids. Which finding best indicates effective resuscitation? A. Dry mucous membranes. B. Decreased heart rate. C. Increased urine output. D. Bounding pulses. Answer: C. Increased urine output. Expanded rationale. Urine output directly measures kidney perfusion. In hypovolemia, renal blood flow decreases. Restoration of greater than 30 milliliters per hour urine output indicates improved circulating volume and organ perfusion. Strategy tip: when evaluating fluid therapy, trust the kidneys. Urine output tells you if perfusion is adequate. Question 9. A client with acute pancreatitis has serum calcium 7.0 milligrams per deciliter. Which nursing observation is most important? A. Constipation. B. Muscle twitching. C. Lethargy. D. Bone pain. Answer: B. Muscle twitching. Expanded rationale. In pancreatitis, fat necrosis binds calcium hypocalcemia. This causes neuromuscular excitability, twitching, tetany. It's critical because severe hypocalcemia can cause laryngospasm and cardiac irritability. Strategy tip: always link pancreatitis low calcium twitchy symptoms. Question 10. A patient receiving TPN develops confusion, intense thirst, and dry mucous membranes. Serum sodium equals 155 milliequivalent/L. What action is most appropriate? A. Increase TPN rate. B. Stop TPN and start D5W. C. Restrict fluids. D. Administer hypertonic saline. Answer: B. Stop TPN and start D5W. Expanded rationale. Hypernatremia reflects a water deficit, not sodium excess. D5W is hypotonic and helps shift water into cells, reducing sodium concentration. Increasing TPN or restricting fluids would worsen dehydration. Strategy tip: when sodium is high, add water, not remove. Give hypotonic solutions carefully to avoid cerebral edema. Question 11. A client's serum magnesium level is 1.0 milliequivalent/L. Which medication could worsen this condition? A. Lisinopril. B. Omeprazole. C. Furosemide. D. Spironolactone. Answer: C. Furosemide. Expanded rationale. Loop diuretics, like furosemide, increase urinary excretion of magnesium, potassium, and calcium. Low magnesium may cause muscle tremors, seizures, and cardiac dysrhythmias. Magnesium stabilizes excitable membranes. When low, the nervous system becomes hyperactive. Strategy tip: loop diuretics make you lose everything, water plus electrolytes. Always recheck magnesium and potassium when using them long-term. Question 12. An ECG shows tall, peaked T waves in a patient with renal insufficiency. Which electrolyte imbalance is most consistent? A. Hypokalemia. B. Hyperkalemia. C. Hypocalcemia. D. Hypernatremia. Answer: B. Hyperkalemia. Expanded rationale. Potassium levels above 5.0 milliequivalent/L affect cardiac repolarization, producing tall, tented T waves. In renal failure, potassium is not excreted efficiently. Left untreated, hyperkalemia can lead to ventricular fibrillation or cardiac arrest. Strategy tip. T for tall equals K for high. Peaked T equals hyperkalemia until proven otherwise. Always check the lab and EKG side by side. Question 13. A client presents with dehydration and confusion. Which lab result best supports this diagnosis? A. Decreased hematocrit. B. Decreased BUN. C. Elevated urine-specific gravity. D. Decreased sodium. Answer: C. Elevated urine-specific gravity. Expanded rationale. Urine-specific gravity reflects kidney concentration ability. When dehydrated, kidneys conserve water. Urine becomes concentrated, specific gravity greater than 1.030. Low hematocrit or BUN indicate fluid overload, not dehydration. Strategy tip. Think of thick equals dry. If urine looks concentrated or dark, suspect dehydration. Question 14. A client on 3% hypertonic saline develops sudden confusion and restlessness. What is the nurse's priority action? A. Continue infusion. B. Stop infusion immediately. C. Call the healthcare provider. D. Assess blood pressure. Answer: B. Stop infusion immediately. Expanded rationale. Hypertonic saline can rapidly raise serum sodium, causing osmotic shifts and cerebral dehydration. Confusion is an early sign of neurologic toxicity. Stopping the infusion prevents further injury before calling the provider. Strategy tip. With any 4 causing acute neuro changes, stop it first, then assess and notify provider. Question 15. A patient with Addison's disease presents with dehydration and low sodium. Which 4 fluid should the nurse anticipate? A. 0.9% normal saline. B. D5W. C. Lactated ringers. D. 0.45% normal saline. Answer: A. 0.9% normal saline. Expanded rationale. Addison's disease causes aldosterone deficiency, sodium loss, and fluid depletion. Isotonic saline, 0.9%, restores both sodium and water equally, correcting volume deficit without causing fluid shifts. Strategy tip. When both salt and water are low, use isotonic saline. Hypotonic fluids would worsen hyponatremia. Question 16. A client with serum calcium 11.8 mg per deciliter reports constipation and fatigue. What is the most likely cause? A. Hypocalcemia. B. Hypercalcemia. C. Hypophosphatemia. D. Hypermagnesemia. Answer: B. Hypercalcemia. Expanded rationale. Calcium stabilizes neuromuscular membranes. High calcium levels depress cell excitability, leading to muscle weakness, constipation, and lethargy. Causes include hyperparathyroidism and malignancy. Strategy tip. Mnemonic. High calcium equals slow and sleepy. Low calcium equals twitchy and tight. Question 17. A patient with chronic alcoholism has magnesium 1.1 milliequivalent/L and begins having tremors. What should the nurse do first? A. Encourage oral fluids. B. Administer 4 magnesium sulfate. C. Restrict sodium. D. Prepare for dialysis. Answer: B. Administer 4 magnesium sulfate. Expanded rationale. Chronic alcohol use depletes magnesium through poor intake and urinary losses. Low magnesium causes neuromuscular excitability, tremors, and can lead to seizures. For magnesium replaces stores rapidly. Strategy tip. Low Mg equals high risk for torsades de pointes, fatal arrhythmia. Always replace promptly and monitor reflexes. Question 18. Which assessment finding is expected in a patient with SIADH? A. Low urine-specific gravity. B. High serum sodium. C. Weight gain and confusion. D. Dry mucous membranes. Answer: C. Weight gain and confusion. Expanded rationale. Syndrome of inappropriate ADH, SIAD, causes excessive water retention, dilutional hyponatremia. Water moves into cells, especially in the brain, causing cerebral edema and confusion. Urine becomes concentrated, but serum sodium is low. Strategy tip. Remember, SIAD equals soaked inside. Everything is wet, weight gain, low sodium, concentrated urine. Question 19. A client receiving 4 fluids develops crackles and dyspnea. What is the nurse's priority? A. Slow the infusion rate. B. Check urine output. C. Notify the physician. D. Continue fluids as ordered. Answer: A. Slow the infusion rate. Expanded rationale. Crackles and dyspnea indicate fluid overload leading to pulmonary edema. The immediate intervention is to prevent further fluid accumulation by reducing the 4 rate, then assess and notify the provider. Strategy tip. When an adverse reaction occurs from N4, stop or slow first, then call. Safety equals stop the cause first. Question 20. A patient with profuse diarrhea has a bicarbonate level of 18 milliequivalent/L. Which acid-base imbalance is present? A. Metabolic acidosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Respiratory alkalosis. Answer: A. Metabolic acidosis. Expanded rationale. Diarrhea causes loss of bicarbonate, a base, from the intestines, leading to metabolic acidosis. The body compensates with Kussmaul respirations, deep, rapid breathing, to blow off CO2. Strategy tip. Mnemonic. Out the mouth equals alkalosis, vomit. Out the butt equals acidosis, diarrhea. Question 21. A client with heart failure develops a potassium level of 5.9 milliequivalent/L while taking spironolactone. What should the nurse do first? A. Continue medication. B. Encourage banana intake. C. Hold the dose and notify provider. D. Give potassium supplement. Answer: C. Hold the dose and notify provider. Rationale. Spironolactone is potassium sparing. Elevated K levels may cause life-threatening dysrhythmias. Continuing or supplementing potassium can be fatal. Strategy tip. For high potassium plus potassium-sparing diuretics, hold and call provider. Never add more K. Question 22. A client's serum phosphate is 1.5 mg per deciliter and calcium is 11.2 mg per deciliter. Which disorder is most likely? A. Renal failure. B. Hyperparathyroidism. C. Hypoparathyroidism. D. Pancreatitis. Answer: B. Hyperparathyroidism. Rationale. Parathyroid hormone increases calcium while lowering phosphate. So, high Ca superscript 2 and low PO4 superscript 3 hyperparathyroidism. Strategy tip. Calcium and phosphate have an inverse relationship. When one rises, the other falls. Question 23. A patient has serum sodium 118 milliequivalent/L and complains of headache and confusion. What should the nurse monitor closely for? A. Seizures. B. Hypertension. C. Bradycardia. D. Respiratory depression. Answer: A. Seizures. Rationale. Severe hyponatremia causes cerebral edema, increased intracranial pressure and seizures. Strategy tip. When sodium less than 120 equals neuroemergency. Monitor neurostatus and seizure precautions. Question 24. A patient with vomiting for 3 days shows ABGs, pH 7.50, HCO 330, PaCO 240. Which imbalance is this? A. Metabolic acidosis. B. Metabolic alkalosis. C. Respiratory acidosis. D. Respiratory alkalosis. Answer: B. Metabolic alkalosis. Rationale. Vomiting removes gastric acid, H, leading to alkalosis and elevated bicarbonate. Strategy tip. Vomit equals lose acid metabolic alkalosis, diarrhea equals lose base metabolic acidosis. Question 25. A client with diabetic ketoacidosis, DKA, has potassium 5.5 milliequivalent/L. What explains this finding? A. Potassium loss through urine. B. Shift of potassium out of cells. C. Excess potassium intake. D. Renal retention of potassium. Answer: B. Shift of potassium out of cells. Rationale. In DKA, hydrogen ions enter cells and push potassium out, increasing serum K despite total body depletion. Once insulin is given, K shifts back into cells, risking hypokalemia. Strategy tip. Always replace K during DKA treatment, even if it's high initially. Question 26. A patient receiving mannitol for increased ICP shows serum sodium 160 milliequivalent/L. Which is the primary concern? A. Cerebral edema. B. Dehydration. C. Fluid overload. D. Hypoglycemia. Answer: B. Dehydration. Rationale: mannitol is an osmotic diuretic that removes fluid, potentially causing hypernatremia and dehydration. Strategy tip: monitor INO and serum sodium. Hypernatremia equals too much water loss. Question 27. A client with cirrhosis develops edema and ascites. Which imbalance is expected? A. Increased albumin. B. Decreased oncotic pressure. C. Hyperkalemia. D. Increased serum calcium. Answer: B. Decreased oncotic pressure. Rationale: liver failure reduces albumin synthesis. Low oncotic pressure, fluid leaks into tissues and peritoneal cavity. Strategy tip: low albumin equals fluid leaves vessels, edema/ascites. Question 28. A patient with prolonged diarrhea has potassium 2.8 milliequivalent/L. What symptom is most concerning? A. Weakness. B. Irregular pulse. C. Nausea. D. Lethargy. Answer: B. Irregular pulse. Rationale: severe hypokalemia causes cardiac dysrhythmias due to delayed repolarization. Strategy tip: always connect potassium imbalance cardiac monitoring priority. Question 29. A client with COPD has ABG results, pH 7.30, PaCO2 55, HCO3 28. What is the correct interpretation? A. Uncompensated respiratory acidosis. B. Compensated metabolic acidosis. C. Partially compensated respiratory acidosis. D. Respiratory alkalosis. Answer: C. Partially compensated respiratory acidosis. Rationale: high CO2, 55, equals respiratory acidosis, HCO3 is elevated, partial renal compensation. pH is still acidic. Strategy tip: if both CO2 and HCO3 move in same direction, compensation is happening. Question 30. A client receiving 4 fluids develops puffy eyelids and shortness of breath. What is the nurse's first action? A. Stop infusion. B. Check urine output. C. Notify provider. D. Increase flow rate. Answer: A. Stop infusion. Rationale: facial puffiness plus dyspnea equals early signs of fluid overload, pulmonary edema risk. Stopping fluids prevents further overload. Strategy tip: always stop the cause first, then assess. Question 31. A patient's ABG, pH 7.48, PaCO2 30, HCO3 24. Interpretation: A. Respiratory alkalosis. B. Metabolic acidosis. C. Respiratory acidosis. D. Metabolic alkalosis. Answer: A. Respiratory alkalosis. Rationale: low CO2, 30, equals loss of acid from hyperventilation, anxiety, fever. pH is high equals alkalosis. Strategy tip: low CO2 equals breathing off acid. Think hyperventilation. Question 32. A patient on 4 insulin for DKA shows potassium 3.1 milliequivalent/L. What should the nurse do? A. Continue insulin. B. Stop insulin and notify provider. C. Increase flow rate. D. Restrict potassium foods. Answer: B. Stop insulin and notify provider. Rationale: insulin drives K into cells, worsening hypokalemia. Continuing insulin may cause cardiac arrest. Strategy tip: in DKA, always monitor potassium, replace before insulin if K less than 3.3. Question 33. A client's calcium is 6.8 milligrams per deciliter after thyroid surgery. Which intervention is priority? A. Monitor for bleeding. B. Keep tracheostomy tray nearby. C. Check blood pressure hourly. D. Give loop diuretic. Answer: B. Keep tracheostomy tray nearby. Rationale: thyroid surgery may damage parathyroid's hypocalcemia, laryngospasm and airway obstruction. Strategy tip: always link post-thyroidectomy airway plus calcium watch. Question 34. A patient with chronic diarrhea shows low sodium and low chloride. Which 4 fluid is best? A. D5W. B. 0.9% normal saline. C. 0.45% normal saline. D. 3% saline. Answer: B. 0.9% normal saline. Rationale. Normal saline replaces both sodium and chloride equally. Strategy tip. For dehydration with electrolyte loss, isotonic first. Question 35. A patient's calcium is 13.0 mg per deciliter. What intervention helps reduce calcium levels? A. Encourage rest. B. Increase fluid intake. C. Restrict sodium. D. Administer vitamin D. Answer: B. Increase fluid intake. Rationale. Hydration promotes calcium excretion and prevents kidney stones. Strategy tip. High calcium equals flush it out. Push fluids unless contraindicated. Question 36. A client with SIAD is on fluid restriction. Which nursing action is essential? A. Offer ice chips frequently. B. Encourage 2L oral fluids daily. C. Administer hypotonic fluids. D. Provide salt-free diet. Answer: A. Offer ice chips frequently. Rationale. Fluid restriction is hard, ice chips provide comfort without adding large volumes. Strategy tip. SIAD equals limit fluids, not salt. Question 37. A patient has magnesium 3.5 milliequivalent/L. Which assessment is priority? A. Deep tendon reflexes. B. Bowel sounds. C. Pupillary response. D. Skin turgor. Answer: A. Deep tendon reflexes. Rationale. Hypermagnesemia depresses reflexes, risk of respiratory failure and cardiac arrest. Strategy tip. Loss of reflexes equals toxic Mg level, stop magnesium-containing meds. Question 38. A client with dehydration is on NS at 200 ml per hour, urine output equals 15 ml per hour. Next action? A. Continue infusion. B. Notify provider. C. Restrict fluids. D. Encourage oral intake. Answer: B. Notify provider. Rationale. Oliguria, less than 30 ml per hour, despite fluids equals possible renal failure. Strategy tip. Urine output is the most reliable perfusion indicator. Question 39. A patient on steroids develops edema and weight gain. Which imbalance is likely? A. Hyponatremia. B. Hypernatremia and fluid retention. C. Hypokalemia. D. Hypocalcemia. Answer: B. Hypernatremia and fluid retention. Rationale. Corticosteroids cause sodium and water retention, edema and weight gain. Strategy tip. Steroids equals swollen and salty. Watch sodium and BP. Question 40. A client with burns develops serum potassium 6.2 milliequivalent/L. Why? A. Fluid loss. B. Hemodilution. C. Cell destruction. D. Low intake. Answer: C. Cell destruction. Rationale. Burns cause massive cell rupture, release of intracellular potassium, hyperkalemia. Strategy tip. Tissue injury equals K leaks out. Monitor ECG. Question 41. A patient with Cushing's syndrome shows sodium 152 milliequivalent/L and potassium 3.0 milliequivalent/L. What causes this imbalance? A. Decreased aldosterone. B. Excess cortisol. C. Increased ADH. D. Dehydration. Answer: B. Excess cortisol. Rationale. Cortisol acts like aldosterone, sodium retention, potassium loss. Strategy tip. Cushing's equals cushy with fluids and sodium. Question 42. A patient with prolonged NGT suction is weak and dizzy. Which electrolyte is most affected? A. Potassium. B. Chloride. C. Sodium. D. Calcium. Answer: B. Chloride. Rationale. Gastric suction removes hydrochloric acid, loss of chloride, metabolic alkalosis. Strategy tip. NG suction equals low chloride plus alkalosis. Question 43. A client has serum phosphorus 6.0 mg per deciliter and calcium 7.5 mg per deciliter. What condition likely exists? A. Renal failure. B. Hyperparathyroidism. C. Dehydration. D. Addison's disease. Answer: A. Renal failure. Rationale. Renal failure causes phosphate retention and calcium loss. Strategy tip. In renal failure, phosphate calcium always appear together. Question 44. A client receiving potassium chloride 4 complains of burning at the site. Nurse's priority action? A. Stop infusion and check site. B. Apply cold compress. C. Decrease flow rate. D. Flush 4 line. Answer: A. Stop infusion and check site. Rationale: KCl is irritating, extravasation causes tissue necrosis. Strategy tip: never push potassium. Always infuse slowly, max 10 milliequivalent/HR. Question 45. A patient with dehydration is prescribed 0.45% saline. What must the nurse monitor for? A. Cerebral edema. B. Dehydration worsening. C. Hypernatremia. D. Hypoglycemia. Answer: A. Cerebral edema. Rationale: hypotonic fluids shift water into cells, rapid correction may cause brain swelling. Strategy tip: use hypotonic fluids cautiously, especially in neuro patients. Question 46. A client with acute renal failure has NAL 130 and K 6.5. Which dietary teaching is most appropriate? A. Increase fruit intake. B. Avoid salt substitutes. C. Drink orange juice daily. D. Eat potatoes freely. Answer: B. Avoid salt substitutes. Rationale: salt substitutes often contain potassium chloride, can worsen hyperkalemia. Strategy tip: educate renal patients, no salt substitutes, they're full of potassium. Question 47. A patient with metabolic acidosis is breathing deeply and rapidly. This indicates what? A. Respiratory failure. B. Respiratory compensation. C. Hypoventilation. D. Hyperkalemia. Answer: B. Respiratory compensation. Rationale: Kussmaul respirations help blow off CO2 to raise pH. Strategy tip: fast, deep breathing equals body trying to blow off acid. Question 48. A patient on hemodialysis has muscle weakness and low phosphate. Which treatment helps correct this? A. Calcium carbonate. B. Vitamin D supplement. C. Sodium restriction. D. High protein diet. Answer: B. Vitamin D supplement. Rationale: activated vitamin D aids calcium and phosphate absorption. Dialysis patients often need it because kidneys can't activate vitamin D. Strategy tip: low phosphate plus renal disease equals give active vitamin D, calcitriol. Question 49. A client with SIAD has now 118 milliequivalent/L and is confused. Which prescription is expected? A. Hypertonic saline, 3%. B. D5W. C. Lactated ringers. D. 0.45% saline. Answer: A. Hypertonic saline, 3%. Rationale: severe symptomatic hyponatremia requires small, controlled doses of hypertonic saline to raise sodium and reduce cerebral edema. Strategy tip: use 3% saline only in ICU settings, watch sodium correction speed, less than 10 milliequivalent/24 HR. Question 50. A patient on parenteral nutrition has serum sodium 126 and weight gain. What is the most likely cause? A. Too much sodium in solution. B. Excess free water administration. C. Infection. D. Protein deficiency. Answer: B. Excess free water administration. Rationale: excess water in TPN dilutes sodium, leading to dilutional hyponatremia and fluid overload. Strategy tip: for TPN, monitor daily weight and electrolytes, it's easy to overhydrate. And that's it for today's session, nurses. You just tackled 50 tough NCLEX fluid and electrolyte questions, and every single one of them brought you one step closer to passing that exam with confidence. If you found this helpful, don't forget to like, subscribe, and turn on the notification bell, so you never miss another NCLEX prep video. Drop a comment below with your score or tell me which topic you want next. Respiratory, cardiac,